Hi, everybody. Welcome to your overview lecture on urinary tract infections. Keep in mind that your PowerPoint presentations are just a brief overview. Please be sure that you review the corresponding chapters in your text associated with these lecture topics and utilize the additional resources accessed through the links in your course module. So urinary tract infection. Lower urinary tract infections are called cystitis. That means that there's an infection in the bladder. They are typically uncomplicated. And they don't have systemic symptoms. And so that's why we call them uncomplicated. Complicated UTIs are typically associated with functional or anatomic abnormalities. They could be related to pregnancy, which changes both intra-abdominal pressure and places pressure on the bladder, or upper urinary tract infection, pyelonephritis, right? That's a big issue. We don't want the patient to develop a pyelonephritis because of all the potential problems that can cause down the road. And recurrent UTIs. If the patient presents with greater than 3 UTIs in a 1-year period of time, we diagnose the patient with recurrent UTIs, and we'll talk a little bit more about that in just a minute. When you're working with your patient, you want to make sure that you collect your subjective data. We talked about subjective data in your first PowerPoint. Is there any pain? How often are they urinating? Do they have this urgent need to feel like they need to go to the restroom and urinate? Do they feel like they're emptying their bladder? Does it smell bad, right? Do they see blood, obvious blood, in the commode after they've urinated? Are they having suprapubic or back pain is a common. Now, when they get into complicated, you're going to ask, have they had a fever, chills, rigors? Are they experiencing any nausea and vomiting? Are they having flank pain specifically, not just low back pain, which is a lot of people present with low back pain? And what was the rapidity of the onset? And so if they have the heightened things of fever, chills, rigors, nausea, vomiting, flank pain, and rapid onset, it's going to move you towards the suspicion that it's a complicated urinary tract infection. Objective data, well, you're going to do palpation over the entire abdominal area and the suprapubic area. You're going to have your patient provide you a urine specimen. You might notice an odor to that. You're going to look at the characteristics to see if it's the turbidity. Is it cloudy or is it clear? Probably going to do a urine dipstick on that to see what the urine dipstick shows, and we'll talk more about that in a minute. And you're going to evaluate for CVA tenderness. What on your objective exam is going to put your mind thinking in the realm of complicated UTI would be significant tenderness to palpation, particularly in the suprapubic region. If you do a CVA kidney punch, we call it, right? If you do a CVA tenderness evaluation, the patient's going to maybe likely jump off the table. And then, is your patient sitting there shaking or sitting there wanting to vomit or feeling nauseous? And, on your vital signs assessment, does the patient have a fever? Differential diagnoses include pyelonephritis. That's the most troubling. Urethritis, I hate to say urethritis, a simple urethritis, because if you've had urethritis, you probably don't think it's simple, but a simple urethritis. Cystitis, which is the lower urinary tract, the bladder itself. Is it a vaginitis? Sexually transmitted infection? Is there a tumor that is yet to be detected, or is there bogginess and swelling, edematous in the interstitial lining or the bladder lining, and that would be interstitial cystitis. Additional objective information you're going to seek in the form of utilizing some diagnostic testing. Best to have your patient give you a midstream clean catch urine specimen. You're going to utilize something like a ChemStrip 10 to do a dipstick. Positive leuks and nitrites are suggestive or diagnostic for urinary tract infection. Keep in mind, if your patient was taking over-the-counter azo, it may change the results or alter or affect the results of your dipstick. Your ChemStrip can also tell you if the patient has hematuria. If the dipstick doesn't show positive Lukes or nitrites and the patient is demonstrating urinary tract symptoms, then you could engage with clinical microscopy, spin the urine down, prep a slide, put it on the microscope. Greater than 10 white blood cells per high power field is a reliable indicator of infection. Positive, either the presence or the absence of bacteria can give you information about the presence of an infection. If you see red blood cells, usually greater than 4 to 5 or so in a high power field, that's going to be problematic and diagnostic. White blood cell casts seen in clinical microscopy on your slide are diagnostic for pyelonephritis. Your gold standard assessment, however, is your urine culture. And so getting your patient to give you a midstream clean catch is optimum for that. Send it off to a lab, your results come back, and in addition to your culture results, they will have done sensitivity testing if you've ordered it, and mostly it's standard to order urine C and S, right? And then your treatment is based on whether you have a complicated versus an uncomplicated. Be sure you look at the table on pages 639 and 640. So uncomplicated, generic macrobid or Bactrim. Complicated, and particularly men, levofloxacin or ciprofloxacin, so your fluoroquinolones. There are medications that can give some analgesic relief to the urinary system, increase water intake, and certainly address hygienic issues with your patient. What is your follow-up going to look like? For your patient with uncomplicated UTI, you're probably not going to bring them back in. They usually start experiencing relief of their symptoms, sometimes as early as with the first antibiotic dose, but certainly within the first 24 hours. Complicated UTI patient diagnoses, you should follow up with a urine culture to assess the resolution. If you are treating a patient for pyelonephritis in the outpatient setting, you should bring that patient back in within 48 hours. Do another dip, do microscopy, and make sure that the pyelonephritis is resolving. Referral patterns could include a urologist for your patient who has greater than 3 UTIs diagnosed in 12 months. That's recurrent UTIs, right? If your patient had pyelonephritis and your basic metabolic panel or your comprehensive metabolic panel shows now that their urine creatinine is not within the normal range, it's elevated, you might want to send them to a nephrologist for some further evaluation and follow-up. And if your patient's sitting there and things are starting to show significant signs of a complicated UTI, urosepsis is not anything that we want to let go without acute treatment. That might be a patient you might consider sending to the emergency department. And here are your references and your resources for the information for this lecture.